Welcome back from lunch. We'll begin the afternoon session. I want to, first of all, before we do that, I want to thank everyone for the very robust, candid, and direct conversations that we've had in the morning session. And I encourage you to voice any concerns, opinions that you have on the next topics that will be discussed. So let's go on to have Dr. Stephen Anderson present FDA Safety Surveillance Systems. Dr. Anderson, please go forward. Dr. Anderson, were you able to hear me?
Can you hear me?
Now we can, sir.
Okay. How do I move the slides forward?
Just indicate to us when you need them to move forward.
Okay, next slide. So thank you for the invitation to speak. I'm going to talk about our vaccine safety surveillance and effectiveness programs that we have in place for post-licensure or post-authorization evaluation of vaccines. The systems really break down into sort of two larger categories. One is passive surveillance of vaccines. I'm just going to talk briefly about Vares. And then our active surveillance monitoring program. And I'm really going to focus a lot on that aspect in the presentation. And that includes our systems I'll talk about as examples of BEST and then our FDA CMS Partnership. Next slide, please. So focusing just on the passive surveillance, this includes the Vaccine Adverse Event Reporting System. It's a system that's co-managed and shared by CDC and FDA. If you go to the next slide. This is a slide that, and Tom Bakura in the next presentation will be talking more in depth about Vares, so I will leave it to him to talk about that and just give you a few high-level details. In the next slide, as to FDA's sort of role and what we're doing with Vares in partnership with CDC. So I just want to say that there's a lot of coordination between FDA and CDC. We have weekly and biweekly coordination meetings on Vares and in general our sort of our pharmacovigilance activities between offices and FDA and CDC. So CBER does have physicians in my office that will be reviewing the serious adverse event reports from Vares. And this includes sort of reviewing individual reports, but also things like the death reports and conducting investigations into those reports. Conducting aggregate analysis, case series, and a variety of approaches. We also use statistical data mining methods to detect disproportional reporting of specific vaccine and adverse event combinations. Next slide, please. So, all right, so I'm going to talk largely about our active surveillance program. If you go to the next slide. I just wanted to give you some brief background on our active surveillance work. So there is legislative authorization for FDA to conduct active surveillance. One sort of set of legislation is the FDA Amendments Act of 2007. And that really directed FDA to develop systems that I'm going to talk about, such as BEST and Sentinel. And I just wanted to remind people that the number of people that these systems cover were mandated to cover more than 100 million persons. So you're going to see some large database numbers in the systems that I'm going to talk about. There's also the Prescription Drug User Fee Act. There's commitments between FDA and industry on sort of priority areas. That program is renewed every 5 years through and approved by Congress. The program does provide resources to conduct post-market and post-authorization types of surveillance, mostly around safety, and we've extended that to include effectiveness. The next slide. So I just wanted to step back just a minute before jumping into the data systems and talk about considerations for vaccine monitoring as we think about, for these COVID vaccines, what are sort of the data needs. So what we want is sort of rapid data access for near real-time surveillance. I think the next factor we want is sort of large databases of tens of millions of patients for evaluating sort of rare serious adverse events that we might see for these vaccines. We want data that represents sort of an integrated care spectrum, and that means from an outpatient setting. So if a patient gets a vaccine, say in their doctor's office, and then they report to an emergency department or a hospital a few days later, then we'd like to have a system that can cover that sort of continuum of care in those different healthcare settings the patient might visit. We want high quality data, obviously, so that we can assess that the vaccinations did occur and that the events, and we want more information on the types of events so we can adjudicate whether the events are real or not. And then along those lines, we really want data with significant clinical detail, and that may mean access to medical charts. So again, if we identify a safety signal, we want certainty that the signal is really a true signal. The next slide. So I'm going to talk about the FDA Biologics Effectiveness and Safety System. I'll just say up front that the BEST system at FDA is part of the overall FDA Sentinel initiative. It falls under that umbrella. We have several data partners in BEST and several general partners that provide other support to our infrastructure. And those are listed here in the first bullet point. Acumen, IBM Watson, and IQVIA are sort of main contractors, a contract research organization. But we also have large insurers involved, such as HealthCore, Humana, Optum, Healthagen, healthcare providers such as MedStar, and others. We have a large component of academic organizations represented in the system as well. Again, I just wanted to emphasize on the last bullet point, BEST includes really a focus on electronic health records. That will see in a minute as well. And then what we have is more powerful data where we link the claims and EHR data. So you get sort of the benefits of each, where you get the additional granularity to adjudicate serious adverse events that you might see or be interested in evaluating. The next slide, please. Just to give you a flavor for the types of data sources that are in BEST, the claims data sources are listed here, and I just wanted to point to the right column where you see patient numbers represented in millions. So you can see that there are tens of millions of these types of records for representing individual patients. And I just wanted to point out that the bottom three or four are really health insurers. Again, they provide, tens of millions of patients such as Optum, HealthCore, and Healthagen. The next slide, please. And then we have EHR, electronic health record data sources. And so those, again, are listed. And you can see those range anywhere from, could be small, anywhere from 1 or 2 million up to, over 100 million. So there's a lot of potential for these systems. We're still exploring some of them, but they hold a lot of potential for conducting vaccine surveillance. And you can see that there are electronic health record systems represented, as well as those linked electronic health records and claims data that provide, a lot of specificity, but also assurance that you've captured, the vaccinations and the adverse events of interest. So the next slide, please. So the BEST initiative, I just wanted to show you that there's a lot that goes into the BEST initiative. It's an EHR network and a lot of characteristics, like we're looking for short lag times. One thing that we're also doing with BEST is we have sort of more on-demand analytic capabilities to sort of do more tailored investigations and tailored analyses of these large databases. I just also wanted to mention that before we've been using PRISM, which is the post-market rapid immunization safety monitoring system, that is also part of the Sentinel system. And we've used that in the past. And I will say the difference between BEST and PRISM is that BEST really incorporates many of the data partners and nearly all of the large data partners that were in PRISM. So for consistency, we've floated over to use the BEST system, but we still have access to and may rely on the FDA Sentinel PRISM system to conduct some analyses as well. So the next slide. I also wanted to speak a bit about a partnership that FDA has had with the Center for Medicare and Medicaid Services. Partnership has been in place since 2002. I just wanted to say CMS data are nice claims data. They cover a very large population of the elderly, nearly all the elderly in the US, at about 55 million persons greater than 65 years of age. The nice thing going down to the bottom bullet point is that we also have access to medical charts and then also access to sort of that continuum of care with these data. So powerful set of data to do analyses on an important population when we're considering COVID-19 vaccine safety and effectiveness surveillance. So I'll go to the next slide, please. I just wanted to sort of point out, there's a lot of strengths to these data systems, but a lot of limitations as well. So I showed you a lot of data systems and data sets that we have access to, but, not all the claims or EHR data systems that we have can be used to address safety or effectiveness regulatory questions. Each system has its own limitations, or for instance, it may cover certain populations, like the Medicare population covers the elderly. We probably won't see much in children in that data set. Some may be limited to healthcare settings like just hospitals. The level of clinical detail may not be as sort of refined as we would like, and so on and so forth. So there are limitations to each of them, so you kind of have to pick carefully which ones are suitable to do, vaccine safety and effectiveness type of monitoring work. And I'll go on to the next slide, please. I just wanted to talk about for COVID. It's really ongoing work as we're planning. Our plan is to conduct near real-time surveillance, or it's also called rapid cycle analysis. We plan on monitoring 10 to 20 safety outcomes of interest, and those will really be determined on what we see in the phase 3 studies of sponsor safety data that gets submitted to the FDA. We'll also coordinate with our federal partners like CDC, VA, CMS, and others to identify adverse events of interest that we want to follow. And I will say that at the bottom bullet point really just emphasizes our first initial plans to deploy rapid cycle analyses would be to use the CMS data to conduct this sort of near real-time safety monitoring for these outcomes. I'll go to the next slide, please. And then this is really just a list of the safety outcomes that we're thinking about doing for our rapid cycle analyses. It's not all inclusive, and some may be excluded. We're going to prioritize the list and then make determinations about which ones to include. But this really gives you sort of a flavor for the types of adverse events we're thinking about. And these are really drawn from lists of people, like we've partnered with CDC, so CDC has a prioritized list, as well as CEPI and other organizations. So we've drawn from all those lists to develop our own working list. Again, go to the next slide, please. So I just wanted to say that we have significant experience with near real-time surveillance and rapid cycle analysis. So we've been conducting rapid cycles and near real-time surveillance for annual influenza and GBS since 2007. And then we've also done work in the FDA Sentinel PRISM system, where we did a rapid surveillance type of project too, where we looked near real-time at 6 health outcomes of interest during the 2017 and 18 seasonal influenza vaccine. Next slide. I just wanted to talk a bit about our other surveillance plans, because it won't just be around the rapid cycle analysis. So if we identify signals from those rapid cycle analyses, we'll need a capability to identify and sort of adjudicate those signals. So you go from a screening method, which is near real-time surveillance approach, like rapid cycle analysis, and then you want to have more certainty that that event is true. So we would use our other databases to evaluate those safety signals further by conducting either small epidemiological studies or larger sort of self-controlled or cohort studies or more comprehensive protocol-based assessments. Others in the government are also going to be using things like tree scan signal detection efforts for identifying potential signals. And so we would plan to partner with our government agencies to help them in refining and adjudicating safety signals that they might identify. Next slide, please. We're also plan to conduct vaccine effectiveness and surveillance work. It remains to be determined at this time. So I just want to say manufacturers will have a role in conducting vaccine effectiveness post-licensure or post-authorization studies, and we may conduct those types of studies as well. So we're thinking about just general effectiveness studies to look at specific outcomes. That includes subpopulations of interest, so like the elderly, patients with comorbidities, et cetera. We're also interested in duration of protection studies. How long will the vaccine protect a person once they've received the recommended number of doses, and then perhaps others as well. I just want to say that we're coordinating the efforts on effectiveness studies with CDC's NCIRD, and we're doing this through monthly and bi-monthly meetings with them. Next slide. I just wanted to say we have significant experience, FDA does, working along with CMS and CDC, conducting effectiveness studies for the annual influenza vaccine as well as zoster vaccine. And then we've conducted a duration of effectiveness study with the Zostavax vaccine. So we've done probably nearly, I think we've published, nearly 25 to 30 articles in this particular area. So have a significant body of work already and experience in this area. Next slide. I just wanted to just emphasize that this really isn't just an FDA-only activity in looking at safety and even effectiveness of the COVID-19 vaccines, and just remind people that it's a large U.S. government effort that's coordinated. And we're working with CDC, CMS, VA. We have other partnerships with NIH. There's DOD, Indian Health Services. So this really is a big effort spanning several government agencies and a lot of coordination among the agencies. So the next slide just really reinforces how that is done. It's done through a lot of meetings. We're meeting weekly with CDC, regular meetings with VA and CMS. The goal is we plan to share protocols, discussions of safety and effectiveness, outcomes of interest, and then just sharing general plans. And there'll be coordinated planning and conduct of surveillance activities. So that near real-time surveillance, those 10 to 20 outcomes, I would expect that other government agencies will be doing either the same list or a very similar list of number of outcomes in their rapid cycle analysis. And with that, I'll just, next slide, end with acknowledgements, because this is not only a single person's effort myself, it includes a number of other people, including colleagues in my office, CDC, CMS, VA, and our many other partners who work with us on these efforts. And I'll stop there. Thank you very much.
Thank you very much for that presentation. We'll take questions now from the voting members and the liaisons. Dr. Goldman, your hand is up first.
Thank you, sir. So first of all, excellent presentation. Really interested in how we can best work with primary care. I did want to bring up a few potential pitfalls that I really think need to be stressed with the BEST initiative. First, of course, the confidentiality issue goes without saying, and everything needs to be assuredly HIPAA compliant and make sure that the patient's confidentiality is assured. But my biggest concern with the use of EHRs, as it has already been showed, was thrust upon primary care and has been quite burdensome in its implementation and use. When we have to do any type of registry, integration, data mining, frequently that cost for the interface and any other data exchange falls onto the private practice and the community physician. It's quite burdensome and costly. So I think this can be an extremely useful tool for data mining, for finding out adverse events and making sure the vaccines are effectively distributed and communicated. But I just want to make sure that we dovetail on the theme from the previous talk on the importance of support and funding. We do not need an unfunded mandate or any other cost burden, because if we end up requiring and mandating private and community physicians to do this reporting and shoulder the cost of any upgrades or interface to the electronic health record, could make the whole project fail in the community setting. So I just want you to be mindful of that, but thank you for your work. Over.
Well, thank you for that. Thank you for that input. Appreciate it.
Dr. Paling, please go.
All right. Thank you for this presentation, and thank you for sharing how multiple components of the federal government are working together for vaccine safety and effectiveness. In your slide about going from screening to epidemiological analysis, there was a component that mentioned tree scan signals. Would you please expand upon that conversation?
Yeah, so tree scan is a signal detection method. So instead of just looking at our 10 to 20 outcomes, what that enables us to do, or whoever's deploying it, I believe it's able to look at thousands of outcomes, like up to 6,000 or more different types of outcomes, and see if there's any potential signal associated with those in a specific vaccine. And so those might be, you might be thinking about, so think about ICD-10 codes that we would be screening against to look at specific procedures and then outcomes. Is that helpful?
Yes, thank you.
Thank you. Dr. Gluckman?
Thank you. Bob Gluckman, I'm the liaison from AHIP. I had a couple of questions about your use of claims information. The first one, do you have concerns about the lag on when claims information may actually be received from providers versus the timing of the adverse event? And secondly, tying that adverse event to the vaccination, if the vaccination is not paid by the payer, will you have a way to integrate the data sets to assess whether or not that adverse event is truly related to the vaccination?
Yeah, so your first question around the lag. So we have a relationship with CMS, and so we do have access to near real-time data coming out of CMS. So that's why we're proposing to use that. And that lag is really, first we get unadjudicated data, and those data can come in. We're just going to take those on a weekly basis, but they could come at us every few days if we wanted. We were going to look at those every week. And unadjudicated means it's not settled in the chart, and it's not necessarily everything's been coded in the chart. And so that might take like approximately 30 days to resolve. And once that data is entered in, then that gets updated sort of in the next data streams that we get further down the road. So, but the point for CMS is that it's pretty rapid access to almost immediate data, followed by the 30-day lag for, additional coded data. And I think we would have that with any EHR system too, where coding would have to catch up. But you're right, there is a lag challenge with claims data. So, and for some of the other systems that we have, such as Optum or Healthagen, those may go out to 3 months or so. And so again, that would be a challenge to actually do studies in those of rapid turnaround. But for verification with large numbers of patients, it still may be very useful for us to use those types of systems. And then your question about sort of if it's not being paid by a payer, you're right, that could be a potential problem. We're working with CMS and others to perhaps make sure at least the administration of the vaccine is required and needed, so that so if there's a payment made for the administration, then we're hoping the administration not only gets recorded, but what was administered will get recorded. But this will be a challenging area, and we are continuing in the government to work on this challenge.
Thank you. Dr. Bell.
Oh, thank you. I just wanted to say that I appreciate the emphasis in your presentation about collaboration with other government agencies and other groups that are working on vaccine safety in terms of things like harmonizing outcomes of interest and very regular communication, sharing data. I think that's actually going to be extremely important. And in that regard, I wanted to point out that I think this sort of collaboration and coordination really needs to continue through the entire process, so that as potential signals are investigated, that communication continues. And certainly when it comes to communicating to the public, that everyone is well coordinated, so that we're providing clear and information in a transparent kind of way. So I appreciate your efforts in this regard, and support the way you're working to stay very coordinated.
Thank you for that comment. Appreciate it.
Ms. Bata.
Thank you for this overview of the monitoring systems. As I think about the very first phase, which will likely be healthcare personnel and likely be through employers or maybe even the local public health partners, I'm not seeing a system that kind of covers that monitoring outside of VAERS. And I know Dr. Bakura is going to talk about the VSafe, but how are we going to manage the monitoring of those individuals when we don't really have the only databases we're going to have are the registries?
Yeah, I mean, we've been giving some thought to that, and I think you're right. It really is a huge challenge, and I think one of some of the electronic healthcare partners we're looking at do have their own healthcare plans, so their employees would be covered by it. So we would be looking at these employer based insurance plans in hospital systems to actually identify adverse events in those populations in addition to VAERS. But again, that's a new area that we're currently exploring. And I think the other thing is looking at facilities. The other is, nursing homes and skilled nursing facilities. And so we're looking at a variety of approaches. And one is the CMS data do cover those facilities. So we're looking at, can we glean safety information from those facilities? So again, we're getting a little bit of the key populations, but you're right. We have some holes in the populations we're able to identify, especially early on.
Dr. Lee.
Thanks so much, Dr. Anderson, for coming and presenting today. I just wanted to echo Dr. Bell's comments that we really appreciate your engagement in the ACIP Vaccine Safety Work Group, or VAST, and your willingness to coordinate and collaborate with federal partners on a harmonized set of adverse events and protocols, as VAST is planning for reviewing the data and monitoring safety in all the post-market safety surveillance systems that span the federal agencies. As you know, well, we used PRISM to monitor H1N1 vaccine safety in near real time in 2009-10. And since then have been able to use both fresh data as well as the adjudicated claims, which do take longer, but fresh data similar to CMS, could be available from the data partners. that you mentioned. So, my questions are along the lines of Ms. Bata's, which is, thinking about phase 1A. So we're very focused on phase 1A and 1B in the early, 3 to 6 months of our vaccine program. And the CMS data only covers adults 65 and older well. So if the vaccine is not found to be as effective in older adult populations, which we're waiting to see, but it would make a lot of sense for us to think about using Sentinel and BEST to monitor during the early phases of vaccine allocation. So the specific questions I have are, which closed or population-based systems do you think would be feasible to use, aside from CMS, in order to capture potentially those essential worker or populations, or the adults with high-risk medical conditions, as well as healthcare providers? And when do you think those systems would be available? And would they be available for real-time, near real-time surveillance, or would this be retrospective after many months have passed? And then if you do have any plans or protocols in place for using PRISM or BEST, when do you anticipate having an update on these plans, or so that we can understand the scope and the timing of availability of such data?
All right. Well, wow, that's a lot to unpack. So we brought on, for recent partners that we brought on board, we've recently brought on 4 or 5 new claims data partners, and that includes the partners in PRISM as well, like Optum, Healthagen, HealthCore, and Humana. So we have used those in the past, as I mentioned in that one slide, for doing that sort of freshest data approach where we were doing near real-time surveillance on 6 outcomes. So those same partners are going to be in BEST now. So we would plan on exploring with the data partners, if we can repeat that effort again with, safety outcomes again. I think, again, the limitations that we find with the claims databases gets to the chart review. So if we're looking at chart review, we just add on anywhere from 4 months or longer, anywhere from 4 to 8 months in adjudicating outcomes that we observe. So we have ways to look at data upstream and downstream of an adverse event to determine whether it occurred prior to the vaccination and those kinds of things, and do a bit more adjudication. But to get at that medical chart data, that's going to be very hard. So in the age group from basically 18 to 64, we'll be using these, largely the BEST and maybe perhaps the Sentinel system to be capturing that age group. But others are going to be capturing those age groups as well, like VSD. So Tom can talk a bit about that. And then we also have VA system that's also EHR based. So there's going to be a bit of a lag if we're relying on these claims data systems. But again, I think they can provide some useful information. Does that answer all of your points?
Thank you. Just to ask specifically, do you think either Sentinel or BEST might be available in time for, as we're anticipating early vaccine allocation to some of these populations? Just thinking about the next, couple of months, we're preparing for vaccine deployment and whether or not it fits into that timeline.
Well, I think Sentinel is ready. I think we're checking with the new partners in BEST and seeing if they're going to be ready to use the approach we're using. So it's just a matter of a new common data model and transformation of the data into that new common data model approach. And then whether, they can, whether we can get rapid access to that data too and do rapid refreshes. So that conversation, I don't have an answer for that as to the timeline, but it may be 4 months, 6 months before we get an answer out of the new BEST partners, before we're able to, so I won't say get an answer, but I'll say to stand up, the rapid monitoring that we would like.
Thank you. We'll take 2 more questions and then move on to the next speaker. Dr. Kimberlin.
Yes. In the systems that you've described and others I bet we'll hear about through the afternoon, one of the possible adverse event outcomes that will be watched for is multisystem inflammatory syndrome in children. And I'm curious what y'all are going to do about the case definition of that, because the case definition requires evidence of current or recent SARS-CoV-2 infection by virologic or serologic means in the prior 4 weeks. Will the case definition have to be modified in order to be applicable post-vaccination?
Yes, I believe so. So I haven't looked specifically at that outcome to start determining how we're best going to monitor it. So I don't know I don't know. So maybe others perhaps.
If I could offer
others maybe.
Yeah, this is Jose Romero. So if I can offer some comment about that. So there are antigen detection tests that do not rely on the spike protein. They use other structural proteins. Some discussions have been had about that and using those types of assays to document a recent infection. Over.
If I could follow on that, what about vaccine-induced MISC? In other words, not natural infection inducing it, but the vaccine itself. If the case definition requires evidence of wild-type infection, we're in a catch-22 on that.
Yeah, I would agree with that. And to make a determination that somebody hasn't been infected is also fairly challenging.
All right, final question will come from Ms. McNally.
Thank you. I'm trying to make sure that my assumption is correct, that these FDA surveillance systems would be in place regardless of how a COVID-19 vaccine would be authorized. So in other words, whether it was an EUA, traditional pathway, or another regulatory mechanism, such as the expanded access.
That's right. And I think the question gets back to, are those administrations going to be entered into these healthcare systems and how that will be done? And I still think that's the relevant question for those, for those programs.
Thank you.
Okay, we'll stop here. Again, thank you, Dr. Anderson, for answering all these questions. We'll move on to the next presentation by Dr. Shimabukuro on post-authorization safety monitoring plans. And again, thank you for yesterday for jumping in when we were having technical difficulties with the speaker assigned to safety talk.
It's my pleasure. Can you hear me okay?
We can.
Okay. Could you go to the next slide, please? Next slide. So just by way of background, the U.S. government has a responsibility for public safety with respect to vaccines. Our monitoring is independent from manufacturers and covers all vaccines. We maintain the largest, most robust, and most sophisticated monitoring systems available in the United States, and U.S. government agencies collaborate on monitoring. And I think Dr. Anderson did a great job talking about how our efforts for COVID-19 are highly coordinated. Our systems and our methods are complementary, and we collaborate on analysis, especially on signal assessment. Next slide. Want to mention that CDC's Advisory Committee on Immunization Practices has established a COVID-19 vaccine safety technical subgroup. Its purpose is to advise CDC and other federal agency partners on planning and preparation, and to independently review and evaluate safety data. Post-authorization, post-licensure safety data on COVID-19 vaccines will be regularly presented at public ACIP meetings. Next slide. So I'm going to give some brief updates on vaccine safety Datalink monitoring and clinical immunization safety assessment project consult services. But I'm going to try to spend most of my time and focus on really healthcare professionals' role in reporting adverse events to the vaccine adverse event reporting system, and also healthcare professionals' role in facilitating patient enrollment into our new VSafe smartphone-based active surveillance. Next slide. Next slide. So the vaccine safety data link is our large linked system, database system that we do active surveillance and research in. It includes 9 participating integrated healthcare organizations with data on over 12 million persons per year. It's EHR data and administrative data. Next slide. We also have access to charts for chart review I wanted to add. So our planned activities for COVID are near real-time sequential monitoring, rapid cycle analysis, monitoring for vaccine-mediated enhanced disease, studies to evaluate COVID-19 vaccine safety during pregnancy, including fetal death and infant outcomes, tree temporal scan data mining, and other projects as you see below. Next slide. This is a preliminary list of our VSD pre-specified outcomes for rapid cycle analysis. It's very similar, if not identical, to the one Dr. Anderson showed you. And this is because we are regularly coordinating on developing our list of pre-specified outcomes. Next slide. So moving on to CISA, next slide. The Clinical Immunization Safety Assessment Project is a collaboration between 7 participating medical research centers and CDC. They do clinical consult services and clinical research. Next slide. So the CSUP Consult service supports U.S. healthcare providers and health departments on complex vaccine safety questions. It assists with the evaluation of patients with adverse events after COVID-19 vaccine or in making clinical decisions about administering COVID-19 vaccine to a person who may be at increased risk for an adverse event. It's available to U.S. healthcare providers and health departments by contacting CDC info. Next slide. Next slide. So VAERS, or the Vaccine Adverse Event Reporting System, is our spontaneous reporting or passive surveillance system. It's co-managed by CDC and FDA. It is the nation's frontline system for monitoring vaccine safety and the early warning system for detecting possible vaccine safety problems. It has traditionally provided the most rapid information on vaccine safety when new vaccines are licensed and recommended and rolled out to the population. We typically can get information very quickly, often in a matter of weeks, to start characterizing the safety profile of new vaccines. Next slide. VAERS can rapidly detect safety signals and can detect rare adverse events. It's subject to the limitations of spontaneous reporting systems in general, and the main limitation is generally we cannot assess causality from VAERS data alone. VAERS accepts all reports from all reporters without making judgments on causality or clinical seriousness, and it's a hypothesis or signal detection system that requires verification of signals in more robust data systems. Next slide. Approaches to analyzing VAERS data include traditional methods such as clinical review of individual reports and aggregate report review. This is looking at large volumes of automated data. Statistical data mining methods detect disproportional reporting of specific vaccine adverse event combinations in the VAERS database. Next slide. This is a preliminary list of our VAERS adverse events of special interest. The ones highlighted in blue there are adverse events of special interest that we will clinically review, and we'll be analyzing those in a separate database where we're abstracting reports and accompanying medical records where available. Next slide. I want to spend some time talking about healthcare professionals' role in VAERS reporting. Healthcare professionals have been CDC's long-standing partners for reporting vaccine adverse events to VAERS ever since VAERS inception in 1990. And VAERS depends on healthcare providers to identify and report suspected adverse events, even if they aren't sure if a vaccine caused an adverse event. Really, for VAERS, healthcare professionals are our eyes and ears out there. We depend on them to use their clinical judgment to detect possible adverse events and to report those as promptly as possible to VAERS. HIPAA permits reporting of vaccine adverse events and medical documentation to VAERS for public health purposes. And healthcare provider participation in VAERS reporting will enable public health officials to have accurate and timely information on the safety of COVID-19 vaccines. Specific guidance on VAERS reporting for vaccines authorized for use under emergency use authorization will be forthcoming. This guidance is different than for traditionally approved vaccines. This guidance is in progress and will be communicated to healthcare providers when it's final. Next slide. So in order to the process for submitting a VAERS report is fairly simple. All you need is internet access in the office, in the healthcare facility, or just internet access in general, even if you're a member of the public. You simply go to the VAERS website. This is the landing page. This is the first page you see. Up in the left-hand corner there, there's a little link for report an adverse event. You click on that and it takes you to, next slide. It takes you to this page, which is really how to report an adverse event. There are two methods, although I will say nearly all public reports, electronic reports, come in using the online reporting tool, but individuals can use a fillable PDF if they want. You just simply click on that report online link. And next slide. It takes you to the online reporting form. And what you see there on the left are these sections for the VAERS report, split into basically almost topical areas. And just below that, you see what is a miniaturized VAERS form. So it cues you to where you are on the particular form and kind of gives you a completion status. And on the right-hand side, you see the initial data elements for the patient information. That's the section we're on right there. You move through these various forms, you advance to the screen. And next slide. When you get to the final data element 28, you just complete that and you hit the submit button. When you do this electronically, if you've inputted your email address, you'll get a verification that you successfully submitted a VAERS report. If you didn't, VAERS will follow up with you through more traditional ways. Next slide. If individuals are a little more visual and want to see a video, you can go to YouTube, click on that link, and it's a joint CDC FDA presentation on how to use the VAERS online reporting tool. Next slide. I want to next cover our VSafe system. Next slide. VSafe is a new smartphone-based active surveillance program for COVID-19 vaccine safety. It uses text messaging to initiate web survey monitoring. It conducts electronic health checks on vaccine recipients daily during the first week post-vaccination and then weekly thereafter until 6 weeks post-vaccination. And there are additional health checks at 3, 6, and 12 months. It includes active telephone follow-up through the VAERS program with vaccine recipients reporting a clinically important event during any of these VSafe health check-ins. And a VAERS report will be taken over the phone if appropriate. We also capture information on pregnancy status, and it enables follow-up on pregnant women. Next slide. This is a very high-level schematic. So you can see CDC and the vaccine recipient up there on the top. There is this bi-directional communication where we're sending out these text messages for these health check-ins with links to web surveys. Individuals are sending information back to us on their post-vaccination experience. If an individual reports having a clinically important, clinically significant adverse event, which we define that for the purpose of VSafe, is the individual missed work, wasn't able to do normal daily activities or receive medical care. That triggers events at the VAERS call center where they will reach out to the individual, contact that individual, and complete a VAERS form if appropriate. I mentioned that we also capture information on pregnancy status. And for those, we will be following up, CDC will be following up on pregnant women to monitor the health of the pregnant women and monitor the pregnancy for the duration of the pregnancy. Next slide. So VSafe allow estimation of rates of local and systemic reactogenicity and rates of clinically important adverse events following vaccination. and symptoms and conditions associated with these adverse events. Next slide. So we anticipate healthcare professionals will play an important role in VSafe enrollment. Initially, when the program rolls out, it is going to be a manual enrollment process. The individual, the patient, the vaccinated individual will have to take some action to enroll themselves in VSafe. And we are asking that healthcare providers will provide a one-page information sheet to patients at vaccination. What you see on the right here is just a draft section of what is a one-page back and front information sheet. We're still in the process of developing the specific language for this, but it's going to have a URL code up top and a QR code to scan. This will take the patient right to a website where they do a pretty simple registration process, and that kicks off the series of events where we start sending these text messages and start getting information back from the individual. We also ask that healthcare professionals counsel patients on the importance of enrolling in VSafe. So there's really two things that we are going to ask. That number one, you give them this information sheet, which tells them about VSafe, and on the backside has some technical instructions, and that you basically give a very short counseling statement on VSafe and the importance of enrolling in VSafe, and we'll provide information on how to briefly counsel patients on VSafe. We want to make sure that this fits into the normal workflow. We understand that we are asking healthcare providers to do additional work to enroll these patients. We want to make it as seamless as possible. We want to just incorporate it into the normal counseling, where an individual gets a sheet, gets a simple counseling statement on VSafe and the importance of enrolling, and hopefully that will provide incentive for individuals to enroll in the program so we can get information on these early recipients of vaccine, and we plan to keep this going as long as we need to. Next slide. Next slide. So in summary, VSD and CISA and other planned projects are key components of COVID-19 vaccine safety monitoring and adverse event assessment. Vares is the U.S. frontline vaccine safety monitoring system. It has traditionally provided the initial data on the safety profile of new vaccines when they are introduced for use in the population. Healthcare providers can play an important role in identifying and reporting potential adverse events to VAERS. Healthcare providers always have been, they are right now, and they will be our partners in safety monitoring, and we depend on healthcare partners to identify and report adverse events to VAERS. VSafe is a new smartphone-based active surveillance program, and healthcare professionals can play an important role in helping CDC enroll patients in VSafe at the time of vaccination. In the coming weeks, we will do an educational an outreach program and a promotional program targeted to our partners and healthcare providers on VSafe and on the important role that healthcare providers can play in enrolling patients in VSafe. We consider healthcare professionals our partners in safety monitoring, both for VAERS, for VSafe, and the opportunity to participate in CISA activities if they so wish. Next slide. Thanks, and I'll be happy to answer questions.
Thanks for that presentation. I think what we're going to do is, if Dr. Wharton is ready to present, we'll put her slides up and allow her to present, and then we'll ask questions from the group to both of you. Are we ready with Dr. Wharton's slides?
Good afternoon. Thank you. Is the audio okay?
It is fine. Thank you very much.
Great. Thank you. Next slide, please. As Dr. Bakura mentioned, the COVID-19 vaccine safety technical subgroup was organized several months ago, including a number of independent expert consultants, ACIP members, liaison representatives, as well as subject matter experts from federal agencies. And this group has focused on adverse events of special interest, reviewing U.S. government plans for safety monitoring, as well as discussing communication issues. Next. As we are moving toward implementation of a COVID-19 vaccine program, we are transitioning this technical subgroup to a smaller data review group. This is really building off lessons learned from the H1N1 vaccine safety monitoring, where there was a consensus that linkage to a federal advisory committee would ensure transparency, independence, and public accountability. And so the composition of the group will include representation from both the Advisory Committee on Immunization Practices as well as the National Vaccine Advisory Committee, a number of independent expert consultants, ACIP ex officio members from federal agencies and from other federal agencies, as well as liaisons from the Veterans Administration and the Department of Defense. Next. The post-implementation objectives of the group are to review, evaluate, and interpret post-authorization or approval COVID-19 vaccine safety data, serve as a really central hub for technical subject matter experts from federal agencies that are conducting these very important post-authorization or approval safety monitoring projects to share the safety surveillance data, to provide advice on analyses, interpretation, and data presentation, and very importantly, connect to the ACIP COVID-19 vaccines work group on issues of safety data presentation to the Advisory Committee on Immunization Practices and application of safety data to policy decisions. We really do think this structure will facilitate the rapid communication of any safety concerns that are identified to the ACIP. Next. So we're expecting that the work group will have a couple of different types of deliverables. One of them will be COVID-19 vaccine safety technical reports for internal ACIP and CDC and federal partner use, as well as COVID-19 vaccine safety data summaries that will be shared with the public. Next. And that concludes the presentation. Thank you.
Thank you very much. So we will open this up to questions from the work group. I'm sorry, from the voting group and from liaisons. Dr. Golden, please.
Thank you. Real brief, I thank you for the presentations. Dr. Bakura on the VSafe. I just have one potential concern when we look at social determinants of health and underserved areas. We're assuming everyone will have access to cell phones, so that may be a limitation in some areas. And we just need to make sure that we're mindful that while most people do have some form of communication, if we're dealing with indigent, homeless, and other populations, we may want to be extra cautious about how we monitor them, and they may not have ongoing access to care as we would like. Over.
Thank you.
Dr. Coyle.
Thank you for the presentation. I think this is an area that everyone keeps asking, you know, what's going to be happening once a vaccine is available. I did have one question for you about VAERS and whether there's been any consideration for modernizing VAERS to be able to accept electronic messages from an EHR or from a registry. I know that that's been discussed in prior years, but I was just curious if there's a way to fast track that or potentially look at that to get better data this time around.
We have done some work on using basically using computer algorithms applied to EHRs to help healthcare providers identify potential adverse events and then facilitate. If you look at the VAERS form, there's very specific information that's asked on there, and kind of a fully automated push the button type of process, I think is challenging. But we have been working on sort of a facilitated automated process, and we would certainly like to explore that further and look to other ways to, I think, use modern technology and EHRs to facilitate VAERS reporting. I'm not sure, given the timelines, we would be able to get something in place in the next several months, but I think that's the next evolution of VAERS.
Thank you. Dr. Stinchfield?
Yes, thank you so much for the presentations. Question for you, Tom. Will the one-page VSafe information be translated into that number of languages that Amanda showed earlier, or will we be doing that translation at the local level?
So I believe it'll be translated into 5 languages, and I'm not sure what those languages are, other than Spanish is definitely one of them. So it will be provided there will be multiple forms in, I believe, at least 5 languages.
Dr. Paling?
Thank you for these great presentations. The communication that is done culturally sensitively is very important and discussed earlier, and the VSafe is part of that. Is there going to be capturing of the diversity of the United States when people are enrolling into VSafe, and what's the feedback to make sure that it truly represents all the people who are being vaccinated?
So the enrollment process is designed to be quick and not impose a lot of burden on the individual. And so the initial registration process right now does not ask about race, ethnicity. I will say that information is asked on the VAERS form. So for individuals who report a clinically significant adverse event and we follow up with them in VAERS, we will get that information. As far as will this be representative of the population, it is our goal to enroll as many people as possible in as many areas as possible, in as many types of settings as possible. It will be open to anyone, at least right now, if you have the electronic capability to enroll and to get these text messages. And we hope to move to also have an alternate email pathway. That's a goal of ours. Enrollment is voluntary, so I guess what I'm saying is we will do our best to make sure that we enroll as many people as possible in as many settings and as many areas as possible.
Thank you. Dr. Bernstein?
Thank you. Safety surveillance is so critically important. This is an immense collaborative effort, and it's quite impressive. I think I have a simple question, but in yesterday's presentation, when you stepped in, Tom, I thought I saw that 36% of reports to VAERS were from manufacturers. And I wondered, A, did I misread that? And B, I think for trust in what's happening with VAERS, I wondered whether it would be more, the information would be more trusted if it didn't come necessarily through the manufacturers.
So the manufacturer reports, and if Dr. Anderson is on the line, he may want to jump in here. Manufacturers are required to report all at least for licensed vaccines, all adverse events that come to their attention. So a manufacturer report is actually usually it's initiated by a public report. So instead of the healthcare provider directly logging on to VAERS and submitting their report, in the case of a manufacturer report, the healthcare provider would have contacted the manufacturer, and then the manufacturer in turn submits a report to VAERS. So typically, I don't want to say it's a pass through, but it's an indirect way of getting the report into VAERS. We want to make sure that we get all reports of adverse events, as many reports as possible. And so if a healthcare provider or a patient or a parent did decide to reach out directly to the manufacturer, this is the route where that information gets reported to VAERS.
So they don't recommend directly completing it themselves? Is there some interpretation that's made by the manufacturers in reporting to VAERS?
When you say when you say an interpretation, could you clarify?
Yeah, I mean, they're just objectively reporting the events, correct?
Yes, they're basically doing an intake process, and then submitting that information. It actually goes through the FDA electronic submission gateway, and is parsed into the VAERS data fields, and then goes to the VAERS program.
So whether it comes from a healthcare professional or the patient himself or herself or the manufacturer, the data can be equally trusted.
Well, one of the limitations of passive surveillance is that there's inconsistent completeness and quality of the data, and that applies to. I don't want to say some reports are better than others. Some reports from different types of reporters are better than others. I will just say that there is some inconsistency in the completeness and quality of data, and largely depends probably on the person who is actually reporting the information.
Thanks.
Dr. Whitley Williams, please.
Thank you very much. Thank you for this presentation, and also the importance, obviously, of surveillance, even though it is passive. I would just say that lessons learned from our children being at home and not in school. There were many barriers, and I'm concerned about the patient barriers. Not everybody has access, as hard as it is to believe, to the internet. There may be access, obviously, outside. The other thing is sometimes many people have, cell phones that they purchase minutes for, and they're not smartphones per se. So I am concerned. I want to make sure that, as I'm sure you do, that it's all inclusive. And if there's any way of tracking or recording, even if it's by zip code, I think it would help to make sure that we are being inclusive of all communities in recording any untoward effects from the vaccine long term. Thank you.
Good. I see no other questions. Thank you very much. We'll move on to our next presenter, which is Dr. Biggerstaff, who will discuss modeling strategies for the initial allocation of COVID-19 vaccines. Please go forward, Dr. Biggerstaff.
Yeah, thank you. We'll be switching gears a bit here, and I'd like to thank the ACIP for time during today's meeting to discuss these strategies. And I just want to note that I'm presenting on behalf of the modeling team within the Data Analytics and Modeling Task Force. And so there's a lot of people who have helped make these slides possible. Next slide, please. I'm going to spend the next few minutes walking you through some modeling analysis that we conducted to answer the question, what is the potential impact in terms of preventing COVID-19 infections and deaths of initially allocating vaccine to one of the following groups after vaccinating healthcare personnel in phase 1A. Specifically, we're looking at initially allocating vaccine to adults aged 65 plus, adults with high-risk medical conditions, or essential workers. This work builds on previously presented work to the ACIP in August and utilizes additional modeling approaches to ensure a diverse set of methods are utilized for these important questions. Next slide, please. So I'm going to, for the next few slides, I'm going to be describing the methods and focusing on how we stratified the population in the model, the assumptions we made for vaccine characteristics and allocation, and the characteristics of the assumed epidemic scenarios and how they varied in relation to the introduction of the vaccine. We began by stratifying with 5 age groups, 0 to 4, 5 to 17, 18 to 49, 50 to 64, and 65 plus. We then stratify each age group by risk status between low risk, which we define as those persons having no select high-risk medical conditions, or high risk, which we define as having one or more select high-risk medical conditions. The high-risk conditions we considered in this analysis were chronic obstructive pulmonary disease, or COPD, heart disease, diabetes, kidney disease, or obesity. We selected these conditions to match an MMWR analysis of the prevalence of underlying conditions associated with an increased risk of severe COVID-19 illness. From available BRFSS data, about 40% of adults are estimated to be at high risk, with this risk increasing by age. For individuals with a high-risk condition, we assumed a 3 times higher risk of mortality upon infection relative to the low-risk group, based upon a review of the evidence supporting the inclusion of these groups into the high-risk list. Next slide, please. In addition to age and high-risk status, we also stratified by occupational status. About 40% of adults aged 18 to 64 are classified as essential workers, and healthcare personnel make up about 25% of those workers. For these essential workers, we assume that they are only able to reduce their workplace contact rates 35% as much as other adults of the same age. Because this is an assumption, we varied this from 20% to 50% in sensitivity analysis. We based the contact patterns used in the model on a social contacts and mixing study called PolyMod, which was conducted in multiple European countries. The contacts and mixing data were adjusted for United States demographics and were taken from a study authored by Prim and published in 2017. The contact rates are stratified by age group and setting, which were home, work, school, and other settings. Next slide, please. Now we're moving on to vaccine characteristics and allocation assumptions. Next slide. We assumed that a full vaccine course consisted of 2 doses given 28 days apart. The assumed vaccine efficacy for both doses was 70%, with the first dose having 17.5% efficacy, which is 1/4 of the assumed full production. We varied this in a sensitivity analysis where we explore the impact of reduced immunogenicity in adults age 65 plus. In this sensitivity analysis, we reduced the VE in the 65 plus age group by half, which resulted in a VE of 8.75% for the first dose and 35% for both doses. For all analysis, we assume protection from either the first or second dose was achieved 14 days following the vaccination. Next slide, please. Continuing on with our vaccine characteristics assumptions, we assume that every vaccinated person is partially protected, which in the vaccine modeling literature is called a leaky vaccine. We also assumed that the vaccine was infection blocking, which meant that it protected the recipient against infection and subsequent onward transmission to other individuals. This assumption leads to vaccination having benefits beyond those directly vaccinated since transmission is reduced, and this is called indirect protection. For any breakthrough infections, which is an infection in a person who was vaccinated, we assumed no attenuation or reduction of severity or transmission for that infection. Because the above is an important assumption, we also assumed that the vaccine was only disease blocking in a sensitivity analysis. This means that there is no protection against infection or onward transmission for those vaccinated, and the benefit they receive from the vaccine is a reduced risk of severe disease if infected. The only benefits of the vaccine in this sensitivity analysis are among those directly vaccinated. For all scenarios, we assumed no waning of either naturally or vaccine-acquired immunity. Next slide, please. Now I'm going to walk you through our vaccine allocation assumptions for phase 1. In this analysis, we assume there are 200 million courses of vaccine available for phase 1, and it's important to note that a course equals 2 doses since we assumed this is a 2-dose vaccine. In phase 1A, we allocate the first 20 million vaccine courses to healthcare personnel. After the initial allocation to 20 million healthcare personnel, we have 180 million courses remaining, and we move to phase 1B, which consists of adults age 65 plus, adults with high-risk medical conditions, and essential workers. Next slide, please. Within phase 1B, we initially allocate 20 million courses to adults age 65 plus, or adults with high-risk medical conditions, or to essential workers. Once 20 million courses are allocated to members to one of the three groups exclusively, we then allocate the remaining 160 million courses of vaccine to members of the three groups concurrently. For these 160 million, vaccine is allocated proportional to each group size in phase 1B. Next slide, please. It's important when we're thinking about these allocation strategies to understand where we are in the epidemic. So now I'll walk you through how we constructed the hypothetical epidemics for this analysis. Based on preliminary serological data and modeled estimates, we assume that the percentage of the population infected 2 months prior to vaccine introduction was 15%. To understand how the results would vary in scenarios with lower or higher values, we assumed values of 5 or 20%. We estimated the impact of the vaccinations and simulated future epidemic trajectories using compartmental models that incorporated time-varying social distancing mitigation strategies. From these models, we compare the outcomes of the numbers of infections and deaths averted within the 6 months following vaccine introduction for the three initial strategies I just described, compared to scenarios with no vaccination campaigns. Next slide, please. Within these simulated epidemics, we assumed 100% of the individuals were vaccinated are not yet eligible for the second dose before moving to a subsequent phase, and vaccines were administered regardless of infection history, meaning that individuals who had been infected would receive a vaccine. We assumed 10 million people could be vaccinated each week, resulting in members of phase 1A and 1B being fully vaccinated in about 9 months. Persons returning for the second dose were prioritized over persons receiving the first dose. We also varied the timing of the vaccine introduction relative to the epidemic incidence, and we created 3 hypothetical scenarios. In the first scenario, we introduced vaccine before a rise in incidence. In the second scenario, we introduced vaccine as incidence rises, and in the third scenario, we introduced vaccine as incidence falls. The next few slides will illustrate these scenarios and when vaccine introduction occurs. Next slide, please. The next series of slides show epidemic curves for the 3 scenarios along with the day the vaccine can be introduced, which is day 0 on the x-axis and marked by the vertical line. As described, these epi curves are simulated using a compartmental model where we vary the levels of social distancing to achieve the shape of the curve and represent the shape and duration of the epidemic with no vaccination. Because we don't know the height of future peaks, we assume the maximum incidence in each of these curves match the peak incidence from the summer of 2020 in the United States. The scenario I'm showing on this slide is one where a vaccine is introduced before incidence starts rising and then plateaus and begins to decline around 60 days after day 0. Next slide, please. This slide shows the epidemic curves for the scenario where vaccine is introduced as incidence rises. And the day of the vaccine can be introduced continues to be marked by the vertical line on day 0. In this scenario, incidence plateaus and begins to decline around 40 days after day 0. Next slide, please. This slide shows a scenario where vaccine is introduced as incidence falls. Incidence plateaus and begins to decline around 30 days before day 0 in this scenario. Next slide, please. This figure overlays the epidemic curves for the 3 epidemic scenarios, along with the day the vaccine is introduced. The horizontal bars represent each vaccination phase, and the length provides an estimate of how long it takes to fully vaccinate that phase under the administration assumptions of 10 million doses per week. As a reminder, in phase 1A, we allocate the first 20 million vaccine courses to healthcare personnel. After this initial allocation of 20 million, we then move to phase 1B, where we initially allocate 20 million courses to adults aged 65 plus, or adults with highest medical conditions, or to essential workers. Once that initial 20 million courses is allocated to one of the 3 groups exclusively, we then allocate the remaining courses of the vaccine to members of the 3 groups concurrently. Next slide, please. Now, moving on to the findings of these analysis. Next slide. This slide shows the population-wide averted percentage of infections, assuming an infection-blocking vaccine and that older adults receive full protection or efficacy from the vaccine as younger age groups. The bar chart shows the percentage of infections averted by the phase 1 campaign over the 6-month horizon following the introduction of the vaccine. Each group of bars represents the different vaccination introduction times relative to incidence rising or falling, with the leftmost group of bars showing the percentage of cases averted in a vaccination campaign that begins before incidence rises, the middle group of bars showing the percentage of cases averted in a vaccination campaign that begins as incidence rises, and the rightmost group of bars showing the percentage of cases averted in a vaccination campaign that begins as incidence falls. The colors represent the group that receives the initial 20 million doses at the beginning of phase 1B. The green bars indicate that the first 20 million phase 1B courses go to adults age 65 plus. The orange indicate that those initial phase 1B courses go to adults with high-risk medical conditions, and the purple indicate that those initial phase 1B courses go to essential workers. The bracket in each group represents the difference in the averted percentage by allocating those initial phase 1B doses to those age 65 plus compared to high-risk adults. These results indicate that if the goal is to avert more infections, then initially vaccinating high-risk adults or essential workers in phase 1B averts approximately 1 to 5% more infections compared to targeting persons age 65 plus. The difference is greatest in the leftmost scenario where the vaccine is introduced before incidence rises, and there's a very small difference in the rightmost scenario where the vaccine is introduced as incidence falls. While the overall numbers of infection averted drops in the sensitivity analysis where we assumed reduced VE in older populations, the findings of initially vaccinating high-risk adults or essential worker in phase 1B averting more infections holds. Next slide, please. This slide shows the population-wide averted percentage of deaths, assuming an infection-blocking vaccine and that older adults receive full protection or efficacy from the vaccine as younger age groups. The bar chart now shows the percentage of deaths averted by the phase 1 campaign over the 6-month horizon following the introduction of vaccine. The timing of the different vaccination introductions is the same as before, as are the colors for each group initially receiving the 20 million doses at the beginning of phase 1B. The bracket now represents the difference in the averted percentage by allocating those initial phase 1B doses to those age 65 plus compared to essential workers. These results indicate that if the goal is to avert more deaths, then initially vaccinating adults age 65 plus in phase 1B averts approximately 1 to 4% more deaths compared to targeting high-risk adults or essential workers. As before, the difference is greatest in the leftmost scenario, where the vaccine is introduced before incidence rises, and there's a very small difference in the rightmost scenario, where the vaccine is introduced as incidence falls. Next slide, please. This slide shows a population-wide averted percentage of deaths, assuming an infection-blocking vaccine, but now the vaccination protection or efficacy in older adults is half that of the younger age groups. The bar chart continues to show the percentage of deaths averted by the phase 1 campaign over the 6-month horizon following the introduction of vaccine. In this sensitivity analysis, we find that initially vaccinating high-risk adults, age 65 plus, or essential workers in the phase 1B averts a similar percentage of deaths across the scenarios. Next slide, please. My final results slide now shows the population-wide averted percentage of deaths, assuming a disease-blocking vaccine with full protection or efficacy in older adults as in younger age groups. In this sensitivity analysis, the overall height of the bars, which shows the percentage of infections averted by the phase 1 campaign over the 6-month horizon is lower compared to the scenarios with an infection-blocking vaccine. However, the relative findings remain similar. These results indicate that if the goal is to avert more deaths than initially vaccinating adults age 65 plus in phase 1B averts approximately 2 to 11% more deaths compared to initially allocating those doses of vaccine to high-risk adults or essential workers. As before, the difference is greatest in the leftmost scenario where the vaccine is introduced before incidence rises and is approximately 2% in the rightmost scenario where the vaccine is introduced as incidence falls. Next slide. And next slide. This analysis is subject to several limitations. Most importantly, all the characteristics of the vaccines were assumed, and the efficacy and ability of the vaccine candidate candidates to prevent transmission, as well as the time the vaccine may become available, are currently unknown. As shown in this analysis, these assumptions can change the results significantly. It's also important to note that modeled epidemic trajectories are only for illustration and are not forecast. It's currently unknown what magnitude and how many future periods of increasing transmission will occur, and the timing of vaccine introduction relative to those periods. In addition, the overall averted burden should be interpreted cautiously for at least two reasons. First, these values are very sensitive to the future trajectory of the epidemic. We only took a 6-month horizon, meaning that infections and deaths that were averted but beyond the 6-month window were not counted. Second, these findings also reflect an idealized rollout, with minimal delays and 100% uptake among the groups. Importantly, we assume equal administration rates among the 3 groups, but there could be meaningful differences in the speed with which groups could be vaccinated. I want to emphasize that the overall aim of the study was to inform discussions about the relative impact of different initial vaccine allocation strategies, not to estimate the absolute impact of the campaign, which will be difficult to accurately do until we know more about the vaccine characteristics and the time they will be available. Next slide, please. In addition to the limitations just noted, the following inputs were assumed and will require reassessment as more information becomes available. 1, all infections confer protective immunity. 2, immunity, whether naturally or vaccine acquired, doesn't wane significantly within a year of infection or immunization. 3, given exposure, younger age groups are just as likely to become infected as older age groups, meaning susceptibility is independent of age. 4, individuals with comorbidities are just as likely as their peers to practice social distancing and other protective measures. And 5, there is no reduction in VE among those with high-risk medical conditions. Next slide, please. In summary, we found that initially vaccinating adults age 65 plus in phase 1B generally averts the greatest number of deaths, and there's approximately a 1 to 11% increase in averted deaths across the different timing scenarios we considered. That initially vaccinating essential workers or high-risk adults in phase 1B generally averts the greatest percentage of infections, and there's approximately a 1 to 5% increase in averted infections across the different timing scenarios considered. That earlier vaccine rollout relative to increasing transmission, the greater the averted percentage and differences that were found between the strategies. These findings indicate that the differences are not substantial and near zero in some scenarios, especially in scenarios where vaccine is introduced as incidence falls. I think these findings can help emphasize the need to continue efforts to slow the spread, that the greatest averted burden percentages are found when vaccine is introduced prior to increasing activity. Finally, these findings are consistent in the sensitivity analysis we conducted, where the percentage of the population infected prior to vaccine introduction was varied, which were not shown in the presentation due to time constraints. Next slide, please. In addition, I also want to draw your attention to a literature review of peer-reviewed and pre-publication studies that was included as a handout. This review summarizes the impact of vaccination under different initial allocation strategies that were identified by the CDC modeling team during a review of studies that model the impact of vaccination under different initial allocation strategies. This handout includes the summaries of 8 pre-publication studies and provides a further description of the study methods, population, the vaccine strategy evaluated, assumptions, and results. In general, this review found agreement between this analysis and the literature review summary results. Similar to our findings, to minimize deaths, initial doses should be allocated to the oldest age groups, those with high-risk conditions, and our older essential workers. To minimize infection, earlier doses should be allocated to younger age groups, younger essential workers, and school-age children. I think it's also important to note that, like our study, many groups conducted sensitivity analysis, and the results varied by the timing of vaccine availability and number of doses available, differences in susceptibility and VE by age, and the mode of action of the vaccine, and whether it was infection or disease blocking. Next slide. That concludes my presentation, but I'm happy to take any questions.
Thank you very much for that informative presentation. So let me begin by warning the voting members, liaisons, ex officios, and the public that we are going to run long. And I think that we're looking at about an hour projected, extending past the projected deadline or the end of this meeting, which was 4:45 Eastern Time. And we're doing that because we think the questions and the discussion is very robust, and we don't want to cut it short. So keep that in mind, and we'll begin with questions for Dr. Biggerstaff. And I see that Dr. Hunter is up first.
Thanks. Can you hear me?
We can.
Yes.
Great. I think from my point of view, both clinically and from local public health medical consultant, the assumptions you're making in your models make sense to me. In general, I think the vaccine efficacy may be a little bit high, but it's reasonable. But what I'm taking away from especially the sensitivity analyses is that introducing the vaccine earlier prevents more lives, and that the time of introduction of the vaccine has more significant impact on the number of infections and deaths averted than who gets the vaccine first. The other thing that seems to have more of an effect, if I'm reading your graphs correctly, is that whether or not a vaccine is disease blocking versus just just disease blocking rather than infection blocking makes more of a difference too. Am I looking at the graphs correctly and making that comparison correctly?
Yes, I mean, I would agree. You know, I think sort of the findings here and are consistent with sort of influenza sort of modeling kind of analysis that were conducted does show the sort of timing of the campaign is a really important factor in sort of the potential impact of vaccines. I will sort of, again, caution sort of looking at those absolute values as sort of meaningful on their own, but I do think the relative values do provide meaning and sort of when considering potential populations, you know, if there are benefits to speed to sort of reaching administration, that may be a consideration that those sorts of findings help inform. I do think those findings could also sort of help inform discussions of sort of how do you send a vaccine out, potentially as you sort of think through that's in relation to the epi curves, but you know, that those are sort of harder to do when we're sort of making lots of assumptions about sort of everything at this point. And your point about disease versus infection blocking is spot on. They definitely, there will be less potential overall impact if the vaccine isn't able to sort of block onward transmission versus sort of reducing the severity of illness.
Thanks.
Dr. Talbot.
Dr. Biggerstaff, thank you immensely because this is an incredible amount of work. It was more than just one model, and I greatly appreciate all of the effort. I have a question, and I don't know how easy it is to answer, and so I understand if you cannot. If we vaccinate older adults first and continue to keep schools closed because our essential workers cannot be vaccinated, can we model the impact of poor nutrition, falling behind in school, possible abuse and neglect in these kids? Is there a way to look at that?
That's a great question. I mean, there are frameworks and approaches where you can sort of try to add on some of these additional considerations beyond just the health outcomes that we focused on in this analysis. I think where those get tricky and sort of highlighted by the assumptions we even make for sort of more knowable things like vaccine efficacy is sort of what's the risk of sort of those outcomes. How are they distributed? Are there sorts of, you know, factors that increase the risk, which I'm sure there are. So it's possible, I think. It's just a they need to be more complex frameworks utilized that sort of move at the agent-based level. So where they're actually trying to model people and then think about what happens to the individuals in terms of the epidemic and also with some of these kind of social and societal outcomes of interest. So it's possible. I won't say it's incredibly easy to sort of integrate those into analysis like this.
Yeah, I think it's really easy. As someone who participates in COVIDNet, it's somewhat easy for us to determine who has died while hospitalized, but it's been really hard for us to determine the impact of this disease outside of the disease. And I think that's an important part of when we decide who to vaccinate to include. So thank you very much.
Dr. Szilagyi, you go next. I inadvertently lowered your hand.
Yes, thank you, Dr. Biggerstaff. This was a very elegant analysis and an enormous amount of work, and I congratulate you. I have two questions. Have you considered modeling hospitalizations in addition to deaths? And I ask that because of the improved healthcare, medical care that we see now compared to even just several months ago. And then secondly, have you modeled a vaccination of adults in congregate care facilities, skilled nursing facilities as a very small group, particularly if there's a very limited sample and there does seem to be efficacy in very old populations?
Yeah, so with the first question, which I was in the process of writing down and then slipped on, can you repeat that just to make sure?
Have you modeled hospitalization?
Yes, sorry. Thank you. So we just initially started with infections and deaths because those estimates are a little easier to come by than sort of kind of the infection hospitalization ratios, but we're trying to come up with approaches to sort of have robust estimates for that. So I think that's something that can be integrated into this sort of framework pretty easily. I would imagine that most of the sort of qualitative findings won't be that different, since sort of the age groups most at risk for hospitalization will follow the sort of mortality risk, but we can definitely integrate that in future versions of this. And then back to your question about sort of looking at persons in congregate settings. This was presented back in August ACIP, and that work was led by Dr. Rachel Slayton. So I'm going to sort of summarize potentially some of the takeaways from that talk, but it really found that vaccinating the staff in these congregate settings may be more beneficial than just vaccinating the residents, and that's likely because of some of this, infection blocking action, and you're not introducing this the virus into nursing homes. But I direct you to those August 26 slides as well for a little more detailed results of that.
Dr. Gluckman.
Thank you. And thank you very much for a great presentation. I'm the liaison from AHIP, the American Health Insurance Plans. Given the evidence of worse outcomes in people of color and low-income populations, did you do any modeling to assess impact in prioritizing people of color or low-income people as well? And if not, should that be considered?
We haven't done an analysis in that yet, but that is something that would be possible. It would take, I think a little bit of work on the back end of the models, again, sort of bringing in the needs to have good sense of sort of how risk and sort of, mobility or context might vary by the different groups, but it is something that could be incorporated if that would be of use to the ACIP in the future.
Dr. Bell, do you want to offer any comment on that? Because I know the work group thought about this issue. And I don't mean to put you on the spot. I'm sorry. It would be easier if you were in the room. I could shoot a glance at you, but I can't do that.
I think that we have considered a number of different ways to reflect the disproportionate impact on disadvantaged populations. And I think including, for example, using a geographic indicator, something like a social vulnerability index or other index that is perhaps similar. And I think that, we felt that it is important to reflect the disproportionate impact on disadvantaged populations. But for any reasons, some of which I think you'll see in the context of the equity and ethics presentation that is coming after this break, that focusing on race, ethnicity exclusively is probably not the best approach.
Thank you for those comments. Are there any other questions or comments? Okay, so not seeing any. What we'll do is we'll shorten this next break and make it a 10-minute break. We will come back at 23 minutes after the hour. 14 seconds. 23 minutes after the hour. Thank you very much.